Needless to go into the details of the COVID-19 diagnosis, it is a simple diagnosis. Any patient who has laboratory confirmation of the COVID-19 infection, irrespective of the clinical signs and symptoms, that is either by the confirmation by the RT-PCR or by the rapid antigen test or by say CBNAT testing. These patients, when they are coming to us, they will be coming to with these particular symptomatologies. They have fever, dry cough, shortness of breath, sore throat, abdominal pain and loose motions, myalgia, malaise, headache, fatigue, anosmia, loss of taste, diarrhea, loss of smell, anosmia what we call it as. These are the major symptoms, those are going to be there. Interestingly, to know about these particular symptoms, the loss of taste and loss of smell, that is what is anosmia, and ageusia that is there, can be the only and presenting symptoms that can be there in this particular, only and presenting symptom that is going, that could be there in this particular. And importantly again, when somebody is complaining to us about the fatigability, that may be directly correlating with the cardiac involvement. That means that is a marker, clinical marker that may tell us that it could be the cardiac involvement in the form of myocarditis that is there, that is setting in these particular individuals. Not only this, but the CNS manifestations could be in the form of altered sensorium. And mind well, altered sensorium that can be there, could be there because of the hyperglycemia that is there, hyperglycemic coma, or can be there because of hepatic encephalopathy, could be there because of the hyponatremia, hypoxic brain damage, or could there be because of the virus that is directly affecting the central nervous system or brain, what we call it as a direct brain involvement in a patient of COVID-19 disease. These are the symptoms, those are going to be there. Interestingly, one should know about the symptom progression. Once the symptoms, onset of the symptoms that is going to be there, almost 2 to 9 days post exposure. Commonly, the average period that is there is 5 days. That means the virus has to be there in the body for 5 days, and the patients may start getting symptoms after the 5 days of the exposure to this virus. However, again one of the important thing that one should know, even though the patient has become completely or recovered out of this particular virus, the patient can continue to share this RNA virus almost 1 week to 4 weeks even after the symptom resolution. So what is there is, for the initial 1, 2, 3, 4, 5 days, the patient may not be having symptoms, the patient starts, the virus is there inside the body. After 5 days of the exposure, the patient is getting symptoms, and these symptoms could be myalgia, malaise, dry cough, low fever, etc., etc. And these symptoms, what we call it as a prodromal period, may last for a period of 1 week. And after that, what is happening is, after the symptoms begin, after the first week of this prodromal period, what starts is the important phase in this particular individual, and that is the second week, where the patient may start getting very high grade fever, may start getting dyspnea, sore throat like dry throat like feeling, and what is there in the lungs is the pneumonia, it starts settling down. That means on almost 9th to 10th day of the patient's symptomatology, the pneumonia will be there. So this second week is very, very important in the symptomatology of this particular individual. And in the pathology, I told you about the cytokine storm that is creating problem. This is the second week that is going to be very, very important, where the cytokine storm is going to be really the important one creating problem in this particular individuals. As far as the signs in this particular individuals are concerned, there can be tachycardia, increase in the pulse rate, there can be bradycardia, decrease in the pulse rate that can be there, or pulse can be irregular, or pulse can be, there can be a missed beats or arrhythmias, those can be there. The respiratory rate can be normal, or respiratory rate can be very high. The tachypnea that can be there. There can be increase in the work of breathing, so you will be finding that the accessory muscles of the respiration are working. The sternocleidomastoid, the nasal LA, those are active. There can be a blood pressure drop in this particular individuals, or in few of the individuals there can be a slight reactionary hypertension that can be found. On examination of the respiratory system, we will be finding that the adventitious sounds like the crackles are going to be there, because after all it is the lung, when it is getting affected, it is there, it is because of the interstitial pneumonia and alveolar inflammation that is there, because of which there can be crackles, or even there can be rhonchi, those can be there. And rest of the signs, those are going to be there because of the complication those are happening in this particular individuals. And this could be in the form of altered mentation, there can be a delirium, there can be signs of congestive cardiac failure, the patient may have low urine output, oliguria that can be there, some few of the patients, they have bleeding manifestations. Because of the arterial thrombosis that is happening in the peripheral vessels, there can be gangrenous changes or some sort of focal neurological deficit. In fact, it could be a hemiparesis or say monoparesis that can be there. And what is important is, if you try to check the SpO2 in these individuals, the SpO2 could either be normal depending on the partial pressure of oxygen that is there in the arterial blood. It can be normal or it can be low to as low as, even we have found the cases as low as 30% of the SpO2 that can be identified in this particular individual when the patient really is in a serious category. Just by taking help of these particular simple parameters, what is the age of the patient, what is the respiratory rate of the patient, how much is the oxygen saturation, how much is the supplemental oxygen that is requiring for the SpO2 to get corrected, how much is the systolic blood pressure, how much is the heart rate, what is the level of consciousness and temperature. When you take help of all these 8 parameters, one of the important scoring parameters those can be used, NEW score, what we call it as, that is a National Early Warning Score. This is very, very important at the first to identify this NEW score at the first entry of the particular patient, because this NEW score is going to tell us the seriousness of the illness that is there, and this NEW score is also going to tell us where the patient needs to be hospitalized, whether the patient needs directly to be hospitalized in the intensive care unit or is to be kept in the say wards or is to be home quarantine. This can be decided based on this particular NEW score. And these 8 parameters really can be taken help of. I will just quote here one example. Various points those are given from 0 to 3, depending on either plus side of that particular parameter or minus side of that particular parameter. Say for example, if you take help of the age, less than 65 age, when it is there, then we are supposed to consider, we are supposed to give only 0 point. When more than 65 age is there, we are supposed to give 3 points. Respiratory rate, when it is 12 to 20, this is 0 point. 9 to 11, that means the respiratory rate is going down. When it is respiratory rate that is less than 8, we are supposed to give 3 points. And when the respiratory rate is also going much higher, more than 25, then we are supposed to give 3 points. So taking help of all these 8 parameters can be made very easy in these particular individuals. And what is required when the 1 to 4 score that is there is the maintaining the existing monitoring criteria that we are following and increase the monitoring frequency once we find that timely the NEW score calculation is increasing. When it is like this, then we can really, so NEW score is very, very important. It's not going to tell you about the seriousness of the illness, how much time we are supposed to monitor and what sort of treatment strategy that we are supposed to give, that can also be decided based on this NEW score. As far as the investigations in this particular individuals are concerned, all basic investigation needs to be performed. One is the complete blood count, which includes the WBC count, the platelet count, the LFTs, bilirubin, HGPT, HGUT, alkaline phosphatase, RFTs, that is serum creatinine, blood urea, serum electrolytes, uric acid, the random blood sugar, ECG is to be found out, ECG is to be taken out, the acid blood gas analysis is to be done in this particular individuals, and what is important is the NL ratio, that is neutrophil lymphocyte ratio. Very, very important simple parameter that you can take help of, NL ratio, that is neutrophil, absolute neutrophilic count that we are supposed to find it out, absolute neutrophilic count that we are supposed to find out, and the ratio that has to be, normally it should be less than 3.5. Anything that is going more than 3.5, that is a red flag sign, what we call it as, or a warning sign that is there, which may tell us that this patient is going to deteriorate, and what is required is strict vigilance and care is required in this particular individual. So all basic investigations are must. Second one is, as I told you, the inflammation, and inflammation is going to be there. So inflammatory parameters we are supposed to find out. And what are these inflammatory parameters? These are interleukin 6, simple parameter like say ESR, C-reactive protein, the ferritin, the LDH, the triglyceride. All these inflammatory parameters are to be identified or investigated in these particular patients. And mind well, at the beginning, if the inflammatory parameters are normal, then all these inflammatory parameters are to be repeated after day 3 or every third day. These inflammatory parameters are to be repeated. And if first at the basic parameters those are there, if at the first all these inflammatory parameters are abnormal, then we are supposed to repeat these inflammatory parameters every day, or at least alternate day we are supposed to repeat, because the management issues are going to get solved, or what is particular strategy that we are supposed to follow will base on the how much these inflammatory markers those are there. At the same time, we should go ahead with the serum electrolytes and serum amylase. Other investigations like say CPK or CPK-MB, the troponin T, all these investigations will depend on whether the patient has the clinical evidence of myocardial damage or myocarditis that is there. No doubt, I told you the thrombosis is happening in these particular individuals, either in the vessels, small vessels and the medium sized vessels. So to find out whether the coagulopathy is there or not, we should go ahead with the D-dimer testing, prothrombin time, activated partial thromboplastin time and fibrinogen levels in these particular individuals. I told you about the secondary infection that is happening as a complication in this particular individual. To find out whether the secondary infection is happening or not, then obviously we should go ahead with the procalcitonin levels, the blood culture, the urine culture, if the patient is intubated, trachestomized and tracheostomy culture. We should ATT culture that we are supposed to subject the patient for. Similarly, if the patient is having expectoration, then sputum examination and sputum culture the patient needs to be subjected for, and that is really going to tell us what particular organisms, either bacteria or say fungi, those are there, the patient is harboring. Another important thing is the ECG. I told you ECG is not going to give a clue to us about the QTc, but also going to give a clue to us about the arrhythmias, whether they are there or not. Ischemic changes, if they are there, can be identified, and if the ischemic change or QT prolongation that is there can really be, see, once it is seen, then other investigation need to be subject like say electrolytes, calcium and magnesium. Another investigation the patient is to be subjected is the X-ray chest. And remember, it should be at the time of admission. First X-ray, basic X-ray needs to be done, and this X-ray sequentially, serially monitored. I like to quote here, if the patient is in a serious condition, if the patient is in a critical condition, this X-ray chest needs to be performed on daily basis. May not be necessary in a patient who has some other form of the disease like say mild or moderate disease, but in serious, these are how the findings those are going to be there. These are white patches, those are, you can see, are nothing but the infiltrates, and these infiltrates are telling us that this is interstitial pneumonitis, alveolar inflammation that is there. This is very typical finding that is there in the X-ray chest. Here mind well, the X-ray will not be showing the consolidated pattern, X-ray will not be showing the cavitated pattern, X-ray will not be showing the pleural effusion pattern, and once this should, if we get this particular finding like say consolidation or cavitatory finding, then on top of whatever COVID-19 pneumonitis that is there, on top of it some other bacterial infection that is developing, so the impression that we are supposed to carry forward. As far as the CT scan is concerned, yes, in the beginning of the COVID-19 it was of a limited value, or because of the non-availability of this particular finding, many of the patients were not undergoing this particular investigation, but for last almost 5 to 6 months now, many patients are undergoing this particular investigation, and really important tool in the diagnosis, in the follow-up of the patient, in the management purpose, the CT scan is going to be very important. But what is happening is the CT scan is being done in almost each and every patient. That really is not mandatory. There are certain criteria to the patient, which patient is to undergo this particular CT scanning. If the patient has got moderate to severe symptomatic illness, that means the patient has got breathlessness, the SpO2 is falling down, then for quick triaging, these patients should be subjected for the CT scan. In asymptomatic patients, the CT scan need not be performed. In mildly symptomatic patients, the CT scan need not be performed. In asymptomatic patients or mildly symptomatic patients, CT scan is required when RT-PCR testing is not available, or RT-PCR testing is available but the results are going to get delayed for 2 days, 3 days, and the management will hamper just because the RT-PCR reports are not available and the patient will be deteriorating. The time is very important. A timely treatment is going to be very important in this particular patient, but just because of the RT-PCR report is not available, we should not delay in starting the treatment in this particular individuals. Similarly, as far as the management, once the diagnosis is made, when the patient is put on some sort of treatment, to find out whether the patient is, when the patient is symptomatically worsening or symptoms are becoming bad, then again this particular patient, they are supposed to be subjected for the CT scanning. When you are suspecting that it is not only the COVID-19 disease that is affecting the lung, but some other complication that is happening, like say complication like bacterial pneumonia, the fungal pneumonia, cavitary lesions are happening, suspected, then also we are supposed to subject the patient for the CT scanning. Here a word of caution that CT scan or HRCT should not be done before 5 days, because we know that the lung involvement is going to be there almost 8th or 9th day of the illness, or at the on second week of the illness the lung involvement is going to be there, and that is why the CT scan should not be performed before 5 days of the illness unless it is warranted. That patient is rapidly progressing, you are finding that plenty of crackles, those are there, and you know RT-PCR testing is not available at all, RT-PCR report is going to get delayed, then we are supposed to subject the patient for the HRCT. Routine evaluation of the lungs with the help of HRCT in asymptomatic individuals or minimally symptomatic individuals is not mandatory, it is not required. HRCT patient should not cough at all. Somebody is coughing, complaining of the cough and cough. Just because the cough is there as the symptom, cough can be there on day 1 of this illness also, on day 2 of the illness also. But when the cough is there, cough alone is not an indication for going ahead with the CT scanning. Routine pre-surgical evaluation, again the CT scan is not required. CT scan is a tool that is going to give clue to us how many lobes are getting affected. In each lobe, how many percentage of the each lobe is getting affected, that information you will be getting. As you know, there are 5 lobes of the lung are there on both the side, 3 lobes on the right side and 2 lobes on the left side, and each single lobe, when 5% is affected, we are supposed to give a score of 1. 5 to 25% when they are affected, score of 2, 25 to 50% when it is affected, score of 3. Likewise, more than 75% when it is infected, then we are supposed to give score 5. And based on these calculations, we find out maximum score that can be attained is 25. We have seen the patients having a score of 0 also, and we have seen the patients having a score of almost 23, 24 also in this COVID-19 disease. This scoring is very, very important. Again, CT severity index, that also can be calculated just by looking at the HRCT score, HRCT findings. When the CORAD 1 is there, we call it as a CORAD. And here I like to quote here that CORAD 5 is very high suspicion that is there, that is typical of the COVID-19. That is going to tell us that it is COVID-19, and when CORAD 6 is there, it is as good as RT-PCR positive, the patient that is there, when the CORAD 6 that is there. This CT severity score, when it is there, we are supposed to categorize the severity of the illness as mild, moderate, severe. When the score is less than 8, we are supposed to call it as a mild disease. Score of 8 is mild disease, score of 9 to 15 is moderate disease, score of more than 15 is severe disease. This categorization is also very, very important.